Okay. So, so today we are starting the APASL liver cancer preceptorship program, ALCAP. My name is Shuichiro Shina from Japan. I am the president of the APASL 2024 Kyoto. So, liver cancer is the third leading cause of cancer-related deaths in the world, and its global incidence is steadily increasing. So it is important that APASL has a liver cancer program because 70% of the liver cancer patients live in the Asia Pacific region. So this program is quite unique in that the participants can gain knowledge about liver cancer not only through the lectures but also through case studies. So we'd like you to actively participate in discussions. We hope that you will enjoy the program and gain knowledge that will help you in your daily practice. Thank you very much. Okay.
Thank you, Professor Shina, President of our APASL. On behalf of all my colleagues, advisors, the chairpersons of the ALCAP, like to welcome everybody who has joined. This is first of its kind initiative, the master class where the masters will share knowledge on a monthly basis on every second Tuesday of every month for about 2 hours, and we'll discuss about the different aspects of liver, tumors, cancers, and the new developments in the area. This is an initiative by the Asian Pacific Association for Study of the Liver. The main objectives are that we all can treat, we all can diagnose, and we all can do equally well. We are very privileged today that we have excellent moderators, outstanding speakers, and above all, one of the champions, one of the most respected name in the field of liver cancer, not only in Asia, but in the world, Dr. Omata, our dear friend, is going to present a case by itself. The idea of such a case presentation is normally students or fellows present, but when a master presents and discusses a case, it is a unique experience. With this, we would like to invite all of you to please spread this message of the Preceptorship program, where you can perceive, you can make your students, your universities, your other colleagues to join this program and give us your feedback also. And I'm very happy that the APSL Secretariat in Tokyo has taken lead. Our key person will be Dr. Ashok, who is our additional professor and has interest in liver cancer. He'll be coordinating, and we have excellent chairpersons, patrons, and advisors, and of course, all of you. Please give your feedback. I want to thank our chairman, our President APASL, who himself is one of the best experts in liver cancer, Dr. Sheena, for joining. And with these words, our objectives are to learn from each other's experience and grow together. Thank you all. And I would like now to hand over to our moderators for the day, who will take over from now onwards. Professor Jidong Jia and Professor Manoj. Thank you.
Hello, dear professors. Thanks for Professor Sarini's excellent address, and also thank President Sheena's opening speech. It's really a good honor for me to chair this session together with Dr. Sharma. Maybe I introduce the first, then you introduce the second speaker. First of all, I would like to invite Professor Chenjun Liu give the talk on HBV-related SCC rule of viral factors and viral biomarkers. Professor Liu from Department of Internal Medicine, Taiwan University Hospital. He is a young but already well-established scientist and academic physician. Now, Professor Liu, the floor is yours. Professor Liu.
Thank you, Professor Jia and Professor Sharma, for your kind introduction. I'm CJ Liu from Taipei, Taiwan. Today, it is my great pleasure being invited by Professor Sarin to join this liver cancer preceptorship program. My task is to talk about HBV-related HCC. I will focus on viral factors and viral biomarkers. In my presentation, I will briefly go through viral carcinogenesis, role of genotype mutant, currently well-known serum biomarkers, including HBV DNA, as well as quantitative HBs antigen and HBcrAg. I will introduce some well-known prediction model for HBV HCC, and finally, I will briefly touch upon viral integration. Chronic HBV infection is related to liver disease progression from hepatitis, cirrhosis, and hepatocellular carcinoma. As for hepatocarcinogenesis, several factors are involved, include host factor, viral factor, and environmental factors. In this slide, you can see all factors associated with liver disease progression in HBs antigen carriers. Viral factors include HB antigen, high serum HBV DNA, HBV genotype, core promoter mutation, pre-S deletion, quantitative HBs antigen, HBcrAg, and viral integration. HBV-related hepatocarcinogenesis is very complicated. Viral and host factor are involved, as shown in this figure. HBx antigen, pre-S mutant, through involvement of the host pathways, including transcriptional factors involved in cell cycle progression, proliferation, etc., contribute to the hepatocarcinogenesis. HBV is a DNA virus, 3.2 kilobase, encoded 4 genes, include surface core, polymerase, and X gene. The virus replicates via RNA intermediate through reverse transcribed by virus-encoded polymerase. This polymerase has an error-prone activity, so there is a high variation rate per nucleoside site per year. So in the human body, there are many point mutations, deletions, or insertions. When the degree of mutation or insertion is high, it can be categorized into different genotype or subgenotype. And in a single human body, there are many variants of a minor variation called Coxia species. This table shows you a common HBV mutant and their potential clinical or biological significance. Include pre-S deletion is related to the progression of liver disease. S gene mutation is related to diagnosis and prevention of failure. YMDD mutation is related to nucleotide analog resistance. And core promoter mutation include 1762 and 1764 variant are related to a risk of HCC. Different genotype of HBV can be found worldwide, and in Asia Pacific region, genotype B and C are predominant. For example, in Taiwan, in asymptomatic carriers, HBV genotype B was documented in 70, and the genotype C in 30%. However, for patients with more severe liver disease, including cirrhosis and hepatocellular carcinoma, the percentage of genotype C was significantly increased, indicating this genotype is associated with the progression of liver disease and the development of hepatocellular carcinoma. Apart from viral genotype, basal core promoter mutation 1762 and 1764 mutant was also found to be associated with the development of HCC by Professor Jia Honggao from Taiwan. In this case control studies, patients divided into genotype B and C. Apart from sex, age, and the present cirrhosis, actually, basal core promoter mutation was associated with more than 10-fold higher risk of HCC in both genotype B and genotype C. In my hospital, about 17 years ago, we analyzed 200 HCC patients and found that in comparison to 160 HBs antigen carriers by multiple logistic regression analysis, advanced age, male gender, pre-core mutation, basal core promoter mutation, and a viral load greater than 10 to the 5 copies per ml were independently associated with HCC development. Another study conducted by Professor Yu, also from Taipei, Taiwan, our university, demonstrated that baseline HBV DNA and genotype are associated with risk of HCC in comparison to a low viral load, non-C genotype. Actually, higher viral load and genotype C was associated with a 26-fold risk of HCC. As for pre-S deletion, Professor Gao in 2006 already documented that pre-S deletion was quite common in patients with advanced liver disease. For example, in this figure, in HCC and liver cirrhosis stage, pre-S deletion can be documented in about 50 to 60%, and the ratio is highest in patients with genotype C. To clarify the pre-S deletion in HCC risk, we collected 46 inactive carriers and 106 different stages of liver disease with HBV infection. We found that pre-S deletion and basal core promoter mutation were associated with risk of progressive liver disease, and the combination of these mutations was associated with the highest risk, especially when pre-S deletion was integrated into the combination panel. Apart from the traditional genotype and viral mutant, in the next part, I will briefly introduce you the role of other viral biomarkers, including HBV DNA, quantitative HBs antigen, and HB core-related antigen. This figure summarizes the replication cycle of the HBV. cccDNA transcribed into pregenomic RNA, 2.4 and 2.1 kilobase RNA. Thereafter, different viral proteins were produced, including core antigen, P22CR antigen, E antigen, and HBs antigen. Thereafter, the complete viral particle with DNA genome inside was produced. In that case, the HBV DNA in the circulation can be measured. The released HBs antigen, either in small spherical or tubular particle form, can also be measured. Recently, the HBCR antigen consisted of HBC antigen, P22CR antigen, and HB antigen can also be measured in the circulation. Let's first look at the role of viral load in the development of HBV-related HCC. The famous REVEAL cohort reported by Professor C.J. Chen about 17 years ago, conducted in communities in Taiwan, collected more than 3,000 HBs antigen carriers and followed for more than 10 years. In this cohort study, patients with baseline serum viral load greater than 10 to the 4th copies per ml was found to be associated with an increased risk of HCC. And when the serum titer was greater than 10 to the 5th, that is 20,000 IU per ml, the risk of HCC was even higher. So currently, when serum titer was higher than 10 to the 5, that is 20,000 IU per ml, was defined as a high serum viral load. HBs antigen was an important serum viral biomarker to determine the infection or chronicity of HBV infection. However, apart from the qualitative analysis, in the past decade, the quantitative HBs antigen determination has also been shown to be very useful in the clinical prediction of the treatment outcome or natural cause. In the study, in NTUH, we found that in patients with low serum viral load, quantitative HBs antigen can help predict the HCC development. In this retrospective cohort study called ERADICATE-B, Dr. Zheng from my institute and Professor Gao collected more than 3,000 S-antigen carrier patients from 1985 to 2000. All patients had been followed for 3 years. Other disease of the liver was excluded, and patients with adequate serum were enrolled for this statistical analysis. Finally, 2,666 non-cirrhotic patients without treatment were collected and followed in the study. These patients were followed for an average of 16 years. 209 events HCC occurred. Annual incidence of HCC was 0.49%. We first confirmed the findings by Professor CJ Chen that serum HBV DNA is a good marker in predicting HCC risk. And actually, in comparison to quantitative HBs antigen, serum HBV DNA was even a better marker in predicting risk of HCC for 10 and 15 years. Second, for patients with low serum viral load, indicated by HBV DNA titer less than 10 to the 4th copies per ml, the risk of HCC actually is very low. However, although low, some patients still develop hepatocellular carcinoma during follow-up. We thus are interested in clarifying whether the serum viral biomarker could help predict the risk of HCC in patients with low viral load. We use a quantitative HBs antigen with cutoff 1,000 to evaluate whether the high quantitative HBs antigen could predict HCC development in patients with low viral load. And the findings suggested that S-antigen titer equal greater than 1,000 IU per ml had a hazard ratio of 3.2 developing HCC in comparison to HBs antigen titer less than 1,000 IU per ml. This data help us define patients with minimal risk of liver disease progression. E-antigen negative carrier with normal LT, we can first determine serum HBV DNA. If equal greater than 2,000 IU per ml, then the patient had an active HBV infection. If their serum HBV DNA titer less than 2,000 IU per ml, we can further determine the quantitative serum HBs antigen. If their titer less than 1,000 IU per ml, then they would be at a minimal risk of liver disease progression and the development of hepatocellular carcinoma. Quantitative HbCRAg is another serum biomarker. This marker had been shown to have good correlation with serum HBV DNA, and a previous study demonstrated it can reflect the transcriptive activity of the cccDNA. So whether this viral biomarker has any value in predicting the development of HCC was studied in patients with intermediate viral load. We first determined the AURC value in predicting HCC development during 10 to 15 years follow-up using different biomarkers, including HbCRAg, HBV DNA, and HBs antigen. And the data clearly demonstrated that actually HbCRAg had a very satisfactory predicting value in comparison to HBs antigen, and the predicting value was equivalent to that obtained by serum HBV DNA. In comparison to baseline HBs antigen, baseline serum HbCRAg had a higher ALCAP value in patients with intermediate to high viral load. The ALCAP for intermediate stage 0.7 and for high viral load 0.51. So in the later study, we try to use the HBCR-AG to predict HCC in the intermediate viral load category. Let's look at the data from review cohort again. For patients with intermediate viral load indicated by serum baseline HBV DNA level range from 2,000 to 20,000 IU per ml, the cumulative incidence of HCC was about 3.6 during 13 years follow-up. In our retrospective hospital-based cohort, we collected 445 e-antigen negative patients whose serum viral load was intermediate category and ALT less than 40 U per liter. We used the HBCR-AG titer trying to stratify the risk of HCC. We used the cutoff of 10 Ku per milliliter, and data shows that a patient with baseline HBCR-AG equal greater than 10 Ku actually had a higher hazard ratio of cumulative incidence of HCC in comparison to those with HBCR-AG titer less than 10 Ku per milliliter. In this e-antigen negative patient with ALT less than 40 U per liter, we stratified the HCC risk by HBV DNA, HBs antigen, and HBCR-AG levels. This figure shows that the cumulative incidence of HCC would be high if the serum HBV DNA was greater than 20,000 IU. The risk of HCC was also high in the intermediate stage HBV if the HBCR-AG titer was greater than 10. In the HBV DNA less than 2,000 IU per milliliter, if the serum HBs antigen titer equal greater than 1,000 IU per ml, the cumulative incidence of HCC would be also slightly higher. Based on these viral biomarkers, we can develop a predictive model for HBV-related HCC. For e-antigen negative carriers with novel ALT, we can first determine serum HBV DNA. DNA titer can be divided into equal greater than 20,000 IU, intermediate between 2,000 and 20,000 IU, less than 2,000 IU per ml. If serum HBV DNA in the intermediate category, we can further determine HBCR-AG. If serum HBV DNA less than 2,000 IU, we then determine HBs antigen. For serum HBV DNA greater than 20,000 IU, the risk of HCC will be high. For intermediate HBV DNA, if HBCR-AG greater than 10, the risk of HCC was also high. Intermediate viral load, if HBCR-AG less than 10, then the risk of HCC is minimal. For serum HBV DNA less than 2,000, if S antigen titer also less than 1,000, then the risk of HCC was also minimal. For DNA less than 2,000, but S antigen titer equal greater than 1,000, the HCC risk would be intermediate. We try to develop a predictive model for HBV-related HCC based on the viral factors according to our previous series studies. Apart from our predictive model, actually currently there are many HCC risk scores for patients with treated versus untreated chronic hepatitis B. In this table, show you the HCC risk score for patients with HBV who are not treated. Various score has been shown that the discrimination power range between 0.8 to 0.92. Predictor components of HCC risk score for patients with untreated chronic hepatitis B are shown in this table. Briefly, viral factor, liver function test, cirrhotic status, and liver stiffness were major predictor components. As for patients with chronic hepatitis B and receiving active antiviral therapy, several risk scores have also been developed for predicting of HCC, and the discrimination power range between 0.7 to 0.83. This table shows you the predictor components of HCC risk score for this patient with patient under active antiviral therapy. When all these predictors and components were reviewed in the untreated versus treated scores, usually age and gender are common component variables. And for the untreated population, biomarkers of HBV replication are often included. However, for the treatment patient, usually measurement of fibrosis and liver function will be important component. Overall severity of cumulative injury in the liver is a major HCC risk determinant in chronic hepatitis B, whose viral replication has been controlled well by antiviral therapy. Finally, I will briefly talk about the role and the status of HBV integration. HBV DNA integration is a quite unique feature for viral carcinogenesis. During the life cycle, because of the reverse transcription, the HBV DNA had the chance being integrated into the host genome. Recent study published in Gut 2021 demonstrated that HBV DNA integration can occur in ENT-negative patients with chronic hepatitis B, and the integration can be localized in genes involved in carcinogenesis. For ENT-negative patients, from the liver tissue analysis, for low serum viral load patients, the integration can be found in 25%. And for patients with high serum viral load, the integration can be found in as high as 56% of the subject with ENT-negative chronic hepatitis B. HBV DNA integration can lead to selective clonal expansion and HCC development. Early during the viral infection, integration can occur randomly. After the integration, some of the clone may have some growth advantage and survive. Thereafter, through cis and trans effect from integrated DNA, the oncogene expression may be enhanced and the tumor suppressor gene may be suppressed. And finally, the hepatocyte may have the chance for malignant transformation. In a recent clinical trial, Professor Xu from Taiwan first tried to clarify whether integration was common in patients with chronic hepatitis B, and whether antiviral therapy has any impact on the replication and the integration status. Patients with chronic hepatitis B serum ALT range from 1 to 2 times upper limit of normal, receive 3-year continuous TDF or placebo. Data shows that at baseline, viral integration was common and can be documented in about 90% of the patients. Very interesting, after 3-year continuous TDF therapy, the transcriptional active viral integration was decreased by about 3.3-fold in the TDF continuous therapy group. In comparison, for the placebo, the viral integration was reduced by only 1.8-fold. Each HBV-related HCC has quite unique integration. Professor Ye tried to clarify whether the virus host chimera DNA can be used to predict the recurrence of HCC in a patient receiving curative operation. And data show that in the circulation, if the tumor-specific chimera DNA can be detected, usually the recurrence rate will be high in comparison to the subject whose chimera DNA could not be detected after operation. Mr. Chairman, ladies and gentlemen, Based on my presentation, I would like to conclude that HBV genotype, pre-S, basal cell promoter, and pre-core mutation are associated with development of HCC. Combination of HBV mutations rather than single mutation was associated with a higher risk of liver disease progression, including HCC development, especially when pre-S deletion was integrated in the combination panel. Serum HBV DNA, quantitative HBs antigen, and HBCR levels help identification of HCC risk in different viral loads. Value of viral integration in hepatocarcinogenesis in clinical practice needs to be clarified. Clinical prediction model for HBV-related HCC can be developed. Finally, I would like to welcome all of you to attend the APASL single topic conference on May 14 to be held in Kaohsiung next year. I thank you for your attention.
Thank you, Professor Liu, for your excellent talk. You summarized the update studies, I think mostly from Asian Pacific area, and especially from your own institute, this excellent works. So now I think we have some minutes for discussion. Is there any, here?
Yes.
Okay, yeah, there is some, yes, please.
So, we know that HBS has different forms like large, middle, and small. So is there any possibility that various types of HBsAgs, for example, middle and large, they may be accumulating more in HCC patients, and the treatment response to decline in various forms, not of the total, but of the different forms, large, small, or medium size, they may be responsible for accumulation and leading to HCC.
Yeah, thank you, Shama, for this very excellent, wonderful question. Actually, HBs antigen secreted into the circulation can be in various forms. However, and some HBs antigen come from the integrated DNA. So it is very important to clarify the different source of the HBs antigen and the different form of the HBs antigen, the role in the development of hepatocellular carcinoma. And one important question, limitation is how to assay the different form of the HBs antigen. Recently, some novel technique have the chance to examine this issue. So maybe in the future, we need to clarify this very important question. However, in our cohort, in our hand, we still do not have the technique or assay to differentiate different form or different source of HBs antigen in the circulation. Thank you.
Thank you, Professor Liu.
Then Dr. Abbas?
Omata.
Okay, Professor Omata.
Yes.
Professor Omata.
You know, when you talk about the integrants, it's fine to see the DNAs, but if it's functionally active, you have to check the RNA sequence, in other words, the expression of integrants or fused with the genomic DNAs. Nowadays, many people doing a single cell RNA sequences. From that aspect, any new update on this matters, in other words, whether the integrants are actually transcribed into the in the human cell hepatocytes, and then if it does, maybe the technology of the single sequencing may pick the ones transcribed from the integrants, and then that may more closer to talk about and the elucidation of the carcinogenesis. I mean, just integrants may not be working. So to prove that, single sequencing may give a lot of new ideas on then the way to prove the association between the two. How do you think about that? Our update us?
Yeah, Professor Omata, you are really expert. Your question is to the key point. Currently, we only see the change of the viral integration, transcriptionally active or not. However, the assay to determine the transcriptionally active is not solid enough. And why you mentioned the single cell assay or the RNA-seq is quite important. And all this data may help to confirm the role of any treatment in the status of the viral integration change. But unfortunately, the current data was still quite limited. In the future, we need to clarify in this issue. Thank you for your suggestion.
Yeah, the expansion of the knowledge about by the single cell sequence, RNA sequencing is so huge. So I can follow all of them. That's why I ask you. So maybe please update us.
Very important. Thank you. Yeah.
Okay, Professor Abbas, your microphone need to unmute it.
Okay.
Okay,
It's now
okay, fine.
unmuted. Yeah, I just want to know that there are now new viral markers, but there are also tumor markers like we already know, and we'll be discussing that. So is there any correlation of viral biomarkers with tumor biomarkers? Like if there is elevated of hepatitis B correlated antigen more, then there will be more production of alpha fetoprotein or des gamma carboxyprothrombin because of the different pathways. There are different biomarkers when they are active. Viral biomarkers, they may initiate different pathways resulting in different tumor biomarkers. So are there any studies related to that?
Yeah. So
Yes, that just one word comment. That's exactly what I would like to ask Professor Liu. Thank you.
Yeah, some viral marker has been shown to correlate with the tumor marker. As I mentioned, the study by Professor Ian and Professor P.J. Chen, they used the chimera DNA. The chimera DNA comes from the integration between the host and the viral genome. And actually, the viral integration, the chimera DNA titer correlate with the alpha fetoprotein very well. So
Okay.
study support this speculation. Thank you.
So that means the kind of a functional correlation between these kind of markers and the pathogenesis or the oncogenesis of that's very important for our understanding of this disease. I think Professor Tawandi also raised the hand.
Right. I just to CJ, very nice talk.
Thank you, Professor Tawandi.
I just to bring back to the real world where these kind of viral markers are not available. So then it seems that the reach of HCC depends on sex and viral load. That is the most in most predicted models. And for eradication of chronic viral hepatitis B in the next few years, can we just look at some of the models that can initiate the treatment where the sophisticated markers are not available in many countries?
Yeah, thank you. Actually, as I mentioned in the final part of my presentation, some very simple clinical model can be used to predict HBV-related HCC, including for the untreatment and for the treatment cohort. And very important for the treatment cohort, maybe we should determine the liver severity liver reserve status. And for the untreatment cohort, we may need to determine the HBV replication status. And all these simple markers, including the ALT level, age, gender, I think that can be used to be applied to predict the risk of HCC. And for the untreatment part, actually, the HCC calculator has been developed about 1 decade ago by Professor C.J. Chen from Taiwan. Also, the so-called the HCC risk calculator, it is very efficient in the prediction of HCC in the non-cirrhotic population.
Yes, I think
Thank
that
you.
the earlier we started the higher the reduction from HCC, right?
I agree. Yeah. So we should for the goal of elimination of HBV, I agree the treatment criteria maybe should be loosened gradually in the near future.
Thank you.
I think you can maybe just very briefly answer a question from the text. With the current potent NA for treated chronic hepatitis B, the role of HBCR-AG is reduced or not?
Very simple, very important for the treatment cohort. Actually, HBCRG level has also a role in the prediction of clinical outcome. Thank you.
Okay, thank you for your excellent talk and for the discussion. I think we are several minutes already behind schedule. I would like to hand over to Professor Sharma. Professor Sharma, may you kindly introduce the next speaker?
Thank you, Professor Jia. So let's move on to the next speaker. And he is Professor Asahiro Morishita. He is from Department of Gastroenterology and Hepatology from Kagayawa University, Japan. And he will be deliberating on surveillance of HCC for whom, why, when, and how. Professor Morishita, please.
Professor Morishita, unmute, please.
Sorry. Professor Shina, Professor Sarin, Professor Sharma, Professor Han Chirin, Professor Ji Donja, thank you very much for giving a very good opportunity for this presentation. Today, I'd like to talk about the surveillance for HCC, for whom, why, when, and how. So, APASL Oncology 2022 single topic conference was held in Takamatsu last September. The conference has a very exciting presentations and enthusiastic discussion. Thank you very much. So as a background, with the spread of antiviral agent against hepatitis B and hepatitis C virus, viral SCC has decreased. Non-B, non-C SCC is rapidly increased. Non-B, non-C is mainly caused alcoholic liver disease and non-alcoholic fatty liver disease. This slide shows a large Japanese multi-center study. You can see the non-B, non-C SCC is gradually increased from 1991 to 2015 in Japan. So from 1991 to 2010, the percentage of non-B, non-C SCC is 15.8. But on the other hand, from 2011 to 2015, the percentage of non-B, non-C SCC is 28.3. So this slide shows the previous study. You can see the red circle. You can see the non-B, non-C SCC is also gradually increased from 2003 to 2017 in Japan. So this slide shows the overview of surveillance of SCC. The first, who should be screened or who should not be screened, for whom? Why is the second, why the SCC surveillance necessary? Why? The third, surveillance interval, when? The fourth, which modality is to be used for surveillance? How? Including imaging tests and the tumor markers. So the first of all, who should be screened? SCC is highly influenced by HBV and HCV involvement and lifestyle habits. Risk factors other than viral hepatitis are cirrhosis, male alcohol consumption, smoking, fatty liver, or diabetes mellitus. The economic situation of each country also determine which surveillance method are cost effective. So in patients at high risk of developing SCC, intensive surveillance is recommended. So you can see the table, the chronic hepatitis patients with HBV, the SCC risk is 3 to 5%, with SCV 2 to 7%, with NAFLD and NASH 2 to 4%, with PBC 2 to 3%. On the other hand, the chronic HBV carriers who are non-cirrhotic and HBs antigen positive, and Asian females more than 50 years, the SCC risk is 0.3 to 0.6. Asian males more than 40 years, the risk of SCC is 0.3 to 0.7. So the cirrhotic patients, the 5-year cumulative incidence of SCC is 4 to 30%. And there is a need for surveillance strategies in terms of cost effectiveness. You can see these figures. The 5-year cumulative incidence in SCV-related cirrhosis, 30% in Japan, 17% in Europe and the United States. In HBV-related cirrhosis, 15% in Taiwan and Singapore, 10% in Europe. The others, in others, 21% in hereditary hemochromatosis, 8% alcoholic cirrhosis, and 4% in PBC. So the study examined the cost effectiveness indicate that surveillance strategies should be implemented if the annual incidence of SCC is greater than 1.5%. The implementation of surveillance strategies may not be cost effective in patients with severe hepatic failure, for example, child-pugh classification C. So therefore, the SCC surveillance is not warranted when patients are ineligible for treatment because of severe liver disease. So non-cirrhotic patients, routine surveillance of patients at low risk of SCC may be inefficient and uneconomic. You can see the table. The group of chronic hepatitis C induced advanced fibrosis, SCC risk is less than 1.5%. The group with chronic hepatitis B, periods younger than 50 years, females or 40 years males, the risk of SCC is less than 0.2%. The group of NAF with non-cirrhotic stage, the risk of SCC is less than 1.5%. So the persistent, this is non-cirrhotic patients with HBV. The persistent HBV infection predisposes the hepatocarcinogenesis in the non-cirrhotic stage. So many expert groups said the surveillance strategies are warranted if the incidence of SCC is greater than 0.2% per year. So the Asian patients with high serum HBV DNA levels are reported to have an annual risk of more than 0.2%. The occurrence rate of SCC is higher in cases with high HBs antigen levels, even HBV DNA levels are low. So therefore, chronic hepatitis B can be eligible for routine surveillance of SCC. So the patients treated HBV, recent advances of new antiviral drug have increased the number of patients achieving sustained suppression of HBV DNA and cell conversion of HBe antigen, while the risk of developing SCC is reduced in these patients, but it is not eliminated. So the patient with persistent HBV infection require continuous suppression of HBV DNA or HBs antigen to prevent hepatocarcinogenesis using nucleoside analogs. So thus, surveillance can be provided for persistent HBV infected patients whose HBV DNA and HBs antigen levels are suppressed by antiviral agent, especially if the incidence of SCC is greater than 0.2% per year. So this slide shows the non-cirrhotic patient with HCV. SCC may occur in persistently HCV-infected patients with advanced fibrosis. Chronic HCV patients with bridging necrosis may be candidate for surveillance. high risk of SCC occurrence after SVR of SCV is involved in the fibrotic stage, and old age, gamma GT levels, and DM in non-cirrhotic patients. This slide shows the patients treated SCV. The removal of SCV by DAAs still does not eliminate the risk of SCC. A DAA treatment reduces the risk of SCC in SCV infected patient and male older age, alcoholism, diabetes, and presence of cirrhosis associated with SCC development. This slide shows our data. Cumulative incidence of SCC after hepatitis C virus eradication using DA treatment. You can see the cumulative incidence of SCC is 1.37% 6 months after DA treatment, 2.44% 12 months after DA treatment, 3.95% 24 months after DA treatments. So patient treated SCV. The overall incidence of SCC after DA treatment and SVR in patient with a history of SCC is 29.6%, very high. And the history of SCC is associated with a higher risk of SCC occurrence after DA treatment. Furthermore, since approximately 50% of SCC incidence and recurrence cases are observed during the 1 to 2 years after DA treatment, SCC surveillance is recommended at shorter interval during the first 2 years. So this slide shows also our data, the cumulative incidence of SCC after hepatitis C virus eradication using DA treatment in patients with a history of SCC. You can see the cumulative incidence of SCC, 25.2% 6 months after DA treatment, 36% 12 months after DA treatment, 57% 24 after DA treatment. So next slide shows that non-cirrhotic patients with NAFLD. The patients with incidentally diagnosed NASH with advanced fibrosis are more likely to have low platelet count and develop SCC, indicating the effectiveness of screening and surveillance. However, since the risk of hepatocarcinogenesis with NAFLD-NASH is not so very high, the routine surveillance of the low-risk group may be insufficient and uneconomical. So the serum liver fibrosis marker, including hyaluronic acid, type 4 collagen, and the platelet count should be evaluated. So recently, the FIFO index and NFS are simple, inexpensive, and widely available tests with a high negative predictive value that effectively exclude advanced fibrosis. Also recently, MAC2 binding protein glycosylation isomer, M2-BPGI, and autotaxin, which is the which are new biomarkers for non-invasive assessment of liver fibrosis progression and carcinogenic risk, have been shown to be useful and clinically applied. The second, why is SCC surveillance necessary? Why? So the etiology of SCC have changed in recent years in Asia, and surveillance strategies need to be established to address changes. SCC is an easy cancer to establish high-risk groups, and there are methods to extensively monitor cirrhotic patients with viral hepatitis. However, even after treatment, these patients remain a high-risk group for recurrence of SCC. So a surveillance strategy is considered cost-effective. Cost is very important. It can achieve its goals at the cost of less than approximately US $50,000 per year of life gains. So appropriate strategies regarding surveillance targets and the method are needed to improve cost effectiveness and outcomes in SCC patients. The third, surveillance interval, when? So the surveillance interval should correlate with the time to tumor doubling. so which has been shown to be 80 to 117 days for SCC. So twice yearly US surveillance for SCC in cirrhotic patients has been shown to improve clinical outcome at a reasonable cost. So you can see the table. The upper part is surveillance every 6 months or less. The lower part is surveillance 6 to 12 months per year. So it means like biannual US, the tumor markers-based surveillance every 6 months is appropriate and currently now recommended. So first, which modality is to be used for surveillance? How? So the first, imaging test. So various imaging tests are clinically applied for SCC surveillance, and US is the most frequently used. Contrast enhanced CT and GD, EOB, DTP, MRI are considered in high-risk patients of developing SCC. Tumor markers, including AFP and DCP, are widely available for SCC surveillance. The first of all, abdominal ultrasound. US is the most widely used modality for SCC screening and surveillance. The reported sensitivity of surveillance US is in the range of 40 to 81%, with specificity of 80 to 100%. So meta-analysis consists of 15 studies showed US was less effective in detecting, especially early stage SCC, with a sensitivity of only 60%. So RHC is very difficult for the surveillance. CT. So since increased arterial blood flow relative to the surrounding liver parenchyma in the characteristic feature of typical SCC, abdominal CT is recommended for diagnosis. So far, the existing evidence does not recommend the use of CT scanning as a routine examination for surveillance of SCC. So accuracy of detection of SCC by MRI, GD, EOB, DTP, MRI is significantly superior to that by contrast enhanced CT. Contrast enhanced CT is widely available, provides stable image quality, and requires less examination time. Therefore, contrast enhanced CT as a surveillance strategy for those at high risk of developing SCC should be considered. So MRIs, GD, EOB, DTP, MRI. This MRI was significantly superior to contrast enhanced CT in detecting SCC, maybe best detective method of SCC in the world. The high cost of maintaining MRI and the long examination time make it difficult to use MRI for surveillance of SCC. So tumor markers. So AFP, alpha-fetoproteins, serum AFP levels is commonly used strategy for surveillance of SCC because it is widely available, inexpensive, and easy to perform. However, AFP measurement alone is not recommended for routine surveillance of SCC because AFP levels fluctuate in patients with cirrhosis with a flare of HBV and CV infection. So in the SCC, smaller than 5 centimeter, a cutoff value of 20 nanogram per milliliter of AFP had a sensitivity 49 to 71% and specificity 49 to 86%, while the cutoff value make it from 20 to 200 nanogram per milliliter of AFP had a sensitivity of 8 to 32%, and specificity is going up and 76 to 100%. The AFP and other markers, the presence of elevated AFP LFCD percent is correlated with SCC tumor with shorter doubling time, and raised serum DCP levels might be indicative of microinvasions. When the cutoff values of DCP were 40 milliAU per milliliter and 100 milliAU per milliliter, the sensitivity and specificity were 41% and 21%, and also 98% 7% and 100% respectively. So DCP has been shown to have better diagnosis accuracy than AFP regardless tumor size, race, and etiology. The sensitivity of AFP and DCP's combination was very low when they were used for strategy to be considered efficacious and cost-effective in detecting SCC at an early stage. So therefore, at present, other than AFP, none of these markers can be recommended routinely as part of surveillance strategy in patients at the risk of SCC. So other serial markers such as APLC% and DCP are used predominantly in the diagnosis rather than surveillance setting. The summary for whom cirrhotic patients and non-cirrhotic patients with HBV, SCV, and NASH. HBV maybe HBV DNA is high, HBsAg is high. SCV advanced with advanced fibrosis, NASH also with advanced fibrosis is important. When 6 monthly intervals, why? The etiology of SCC have changed in recent years in Asia, and surveillance strategies need to be established to address this change. How? The best of the surveillance methods is combination of US and serum AFP. Thank you for your attention. Thank you.
Thank you, Professor Morishita. Now we can have questions. Any question from the panelists? So I have one question, Professor Asahiro. So AFP, use of AFP as a surveillance tool is for example, West doesn't endorse it. We Asians regularly use it. So why is this controversy? So
Contra what?
For use of alpha-fetoprotein as a surveillance tool.
Yeah, AFP is actually maybe many countries we can easily use AFP, right? And so what's the point of question? I'm sorry, it's very, the internet connection is not so good. So
okay, so my question is, at APASL and Asian countries, we are using both alpha-fetoprotein and ultrasound abdomen to screen for HCC. Yes. But ASLD and EASL say that AFP of no use in screening for HCC.
Actually, we are not sure the data, but actually, I don't know, it's maybe AFP is elevated sometimes by only cirrhosis or other diseases. I don't know, maybe, or actually, I don't know why in EASL maybe people don't want to use the AFP.
Yeah, because we regularly use AFP and ultrasound, even we are using regularly. Yeah. And okay, no problem. So we have another question from the question and answer section. So this is an anonymous attendee asking that, what is your experience in using abbreviated MRI? Abbreviated MRI in surveillance of HCC.
Anonymous one or the first one?
This is regarding abbreviated MRI, magnetic resonance imaging.
Ah. Which one? Ah.
I think you can read from the question.
The Q&A.
The Q&A,
which one? Just
may I know your experience?
Yeah, yes.
Oh, yeah. So actually, for surveillance, maybe no, but actually, so we have a lot of high risk patients with cirrhosis. Sometimes, if the tumor marker is very high, we sometimes use MRI. Not only enhanced CD, but also MRI. Maybe 2 times a year, maybe CT and MRI combination in Japan.
For super high risk individuals.
Yeah.
Okay. But not routinely.
No.
Okay. So there is another LAD score. Any opinion on this? And PIVCA? The last question in the Q&A session. How about the use of GALAD score, AFP, L3, and PIVCA?
Actually, I think I usually use AFP and L3 and PIVCA, maybe combination of AFP and PIVCA. So maybe if sometimes if the AFP is very low, but sometimes PIVCA is very high. So it's sometimes it's opposite. So that's why we always use by combination AFP and PIVCA, L3 or PIVCA, L3 and PIVCA.
Okay. Yeah, Professor Abbas has some question.
Yes, if you are given choice to use one biomarker, alpha-fetoprotein or DCP, what would be your choice, DCP or alpha-fetoprotein?
Actually, AFP is, we always use AFP because DCP is sometimes like influenced by warfarin or something like that. So that's why in high risk group, with heart failure or some vessel disease, some patient always taking warfarin, anticoagulant drug. So that's why that affect to the upregulation of PIVCA too. So that's why I always use AFP or AFP L3.
So you mentioned that, yes, you mentioned that addition of DCP with alpha-fetoprotein does not serve much, like it does not increase the sensitivity. Is it true? That or I perceived it? So it means that GALAD score has got no value in that case. So should we stop asking for the GALAD score or measuring the GALAD score? Or
actually, I don't use GALAD score, so maybe we should use.
Professor Tanwandi, he is raising the hand.
Just follow to Professor Abbas. I think in Japan you are using the GALAD score as well for as the recommended by Japanese guideline or something, and also the combinations of the AP and PIVCA2 that call GALAD score, and also ASAP score done in China that been demonstrated more accurate than just isolated AAP. So do you have any comment on that?
Actually, I have never used the GALAD score, so that's why maybe if people say, oh, that is more sensitive and much better, of course we should use it. So maybe combination is not so sufficient. So that's why maybe, yeah, we should use GALAD score.
Thank you.
Okay. So maybe we can have the last question. It is from Professor Diana Payawal. She has written, most of the countries in Asia have an out-of-pocket screening program. So in such a scenario, how will you prioritize which test to use for a screen?
So it means like...
that means the patients are paying themselves for the screening programs.
So actually, the combination of tumor markers and images, right? So maybe completely it's depend on the country, right? So I think it's depend on the economic condition, right? So we always use like if something happens, it's like if the tumor marker is high, we use enhanced CT or MRI directly. So, but for the surveillance, it is very difficult. It's completely depend on the economic situation. So, so we should make a guideline or something. So in Asia, and maybe gas risk was much better, you say. So maybe we should put it in the guideline somehow.
Okay, so we have overshot our time. Thank you, Professor Morishita, for
Thank
this
you.
nice lecture. And may I now request Professor Jia to introduce our next speaker, Professor Omata.
Thank you. I think I don't need to say anything, just the name of Professor Omata. If someone who do not know Professor Omata in this region or in the world, then he or she may not be a hepatologist. Then Professor Omata, I think in the field of hepatitis B and also on the field of SCC for many several decades. I recently have read his early papers on the integration of HBV DNA and also on the diagnosis of HBV SCC. Today, Professor Omata gave us some, I think, case discussion. This is a very, I think, a very interesting format, like grand round, just to show us the real like master class. Professor Omata.
Yeah, Jidong, nice introduction for stone-aged individuals. Great. And maybe you can get started on the pre-recorded ones. So Nakano-san, please. Hello, this is Dr. Omata from Japan. Today, as the start of the ALCAP, I will do a grand round, a case presentation. And the topic I picked today is how to follow SVR patients. Actually, we've done a treatment for Hep C patients. And many patients are now coming to my outpatient clinic because of the follow-ups after eradication of the virus. So I picked the topic. I will present a case. This is a CV positive Japanese lady. Actually, she is now 85 years old. I follow her over 30 years, and eradication of the virus was conducted in 2015. That's a year we almost finished and published our pivotal study of a CV that year. We treated many in 2015. And his original assessment of the liver indicate possible F1, even though there is no histology biopsies. Platelet counts 240,000. And elastography indicated 5.6 kilopascals, and the fatigue change, CAP score was 239 decibels. So maybe it was not in the indication to have an intensive follow-up, but she really wanted to be at my clinic. So I follow her every 4 to 6 months. And then what I have done is for the last 8 years, she came to my clinic 34 times. And then 12 times I've done abdominal US exam and measurement of 3 tumor markers, AFP, lectin binding protein, AFP-L3, and DCP, 30 times for the last 8 years. This combination of 3 tumor marker is very typical and then conventional already for the last maybe 30 years in Japan, and reimbursed by the governmental insurance. So she is doing very well actually after eradication of the virus. But by ultrasound last year, there was a tumor 33 millimeters, and then SCC was suspected, despite the fibrosis is minimal for her. And then instantly we did EOB MRI, and it shows 39 millimeters. The first differential diagnosis include hepatocellular carcinoma. Then I checked the AFP, AFPL3, and DCPs. And these three tumor markers, as you know, the normal range for DCP is it's a normal range anyhow, even though you've done the examination several times. Then AFP also very low, and then L3 is also negative. So this particular case is also triple negative for these three tumor markers. Then we done also CES, suspecting adenocarcinoma, but this was also not elevated. Therefore, we conducted and then we suspected non-hepatocellular carcinoma, and then we conducted laparoscopic surgeries, and it turned out it was cholangiocellular carcinoma, moderately poorly differentiated. So my question today for discussions, I may raise this tumor markers versus imaging. Well, this has been a discussion for decades, for 40, 50 years. So I want to have your opinion, how and whom you do after SVRs. Do you often do the imagings, or do you do the testing just FP alone, or how do you regard how to evaluate the significance of FPL3 and DCPs? And in this particular case, you have to do the CEA or other tumor markers as well. I would like to take your opinions if you have. All right, Abbas, have any questions? What's your opinion about this?
Yes, may I say something? Do we have C99 with us? Because I can see that this was probably not there. And second thing is that ultrasound is, we do ultrasound with alpha-fetoprotein, but ultrasound is not able to pick up cases where the tumor size is very small. Like if you are doing ultrasound alone, it had cost sensitivity of about 45%. But if you combine with alpha-fetoprotein, this would be about 65 or 67%. So we are doing surveillance with ultrasound as well as alpha-fetoprotein to increase the sensitivity for surveillance.
Well, that's in the context of the finding hepatocellular carcinoma, but this case is not a hepatocellular carcinoma. So in a sense, you know, she wants to be checked about whole bodies, not just restricting yourself to the liver. So that's the thing I want to raise, because now I'm checking not just the liver of the cancers, but also got to check the whole things, especially this CCC seems rapidly growing. So even though her age is, she's perfectly all right. So that's the way I'm doing nowadays.
Yeah, yes, we should keep in our mind.
Jidong, how do you think?
Well, there's excellent cases. Actually, there are already some studies showing that HCV, perhaps also HBV infection associated with increased incidence, not only for HCC, it is well known, but also for CCC, cholangiocarcinoma.
Okay.
So in this sense, I mean, we maybe answer your question. In China, we routinely now use ultrasonography every 6 months. At the same time, alpha-fetoprotein. In some hospitals, we use also DCP, also use L3. So, but not for the for cholangiocarcinoma. So I think this is our practice. Thank you.
So this case, if you question which one you take, tumor marker or the imaging, but in this case, tumor marker doesn't look like working, right?
Imaging. imaging.
Yeah, imaging you may take. But may I
Yeah.
proceed to the next slide? Nakano-san, Izumi-san, please. Or I should push the button.
Well,
Could you,
I
could
go
you
ahead
proceed? Could you go ahead?
interesting part of this patient is this tumor markers is steadily, silently moved up incrementally. And after laparoscopic surgery, taken the tumor out, it shows a drop. But it's a slight, very touchy change. This is CA19-9. Obviously, this tumor marker is within the normal range. So if you take a 1 point, maybe it's very difficult to tell this is diagnosis for any cancers, because some people think CA19-9 is non-specific. But from my experience for following these patients, try to find the tumor as small as possible, I think this very incremental, sensitive, and then also interventions of the surgery indicated maybe after removal, tumor marker level, even though it's very low and within normal range, may indicate something. So this is my experiences for decades. I have a lot of impressive cases in that. Of course, CT can tell you where, or ultrasound tell you where the tumor is. But when you really think the tumor marker is not sensitive enough, I don't really think so. I think if you have serial measurements, and then if you are sensitive enough, maybe you can tell this is an informative markers. Informative means, here we are, I am the tumor here, why don't you notice about? So about this discussion, tumor markers, and then imaging techniques, sometimes my experience tells me tumor marker could be more informative if you pick the right one. So another matter on this case is that should we follow this 85 years old lady with fibrosis stage 1 so intensively? Actually, I've done intensive search because 3-4 times tumor marker and the ultrasound. So that's the question. In fact, recently we published a paper in that following 651 SVR cases intensively in a sense, hepatocellular carcinoma was found in 55 cases, but also 52 cases, we found the malignancies other than hepatocellular carcinoma. So should we focus just on the liver matters, hepatocellular carcinoma, or rather other things as well? In other words, whole body care. Let me show this data. Of this cohort we published, we compared one is the data from Japanese general populations and then predicted mortalities based on this 5-year age group matched governmental data, MHLW demographic survey, and then compare with our cohort, 651 patients. Obviously, they are suffering from hep C, and then some of them are cirrhotic. So it's expected maybe their overall survival for years is obviously less than that of the normal population, Japanese age 6 matched ones. This is the expected general population of Japanese. As you see here, is slightly below the one from the SVR patients. In other words, this indicates prognosis of SVR patients is not inferior to the one compared to the age 6 matched same Japanese populations. Therefore, I think now how intensively you have to be careful about these patients is two things. Well, should we focus just on the liver, or also we have to take care of the other things? But can we afford, our nation can afford that kind of the systems, medical systems as total? So that's the questions. So should we follow this 85 years old lady with F1 so intensively? I stop for, and then I may take your questions. It's
All right, anybody? How do you do? Danny Wang.
Yes, yeah, no, it's this is actually George. Because yes, it's an excellent talk, and you always bring in the point. First of all, 85 years old is not considered old in my family. My mom is 92. Yeah, but I think the surveillance is very important. I just have a patient very similar to your case right now in the hospital, just received the radio frequency ablations, who presents in a very similar manner after eradication of HCV 10 years ago with the use of interferon-based therapy. But then they come back with small lesions, so 1 centimeter in segment 8. So I think that they really, well, from our data and in collaboration with my Beijing groups, even SPR after HCV, there are cases of increased hepatocellular carcinomas, and there are also indications that cholangiocarcinoma might be increased. So I think surveillance with ultrasound and also tumor markers in addition to alpha-fetoprotein. Because I want to bring up my case right now is in the hospital who has to have a radio frequency ablations. The alpha-fetoprotein is actually normal, but with a raised CEA and the CA 19.9. Now the tumor marker is coming down after the RFA. So it's interesting that we see, and my patient is 69 years old. So I think that's it's important for us to make surveillance, and maybe for these old cases, we might need other tumor markers to come into play too, because 1 centimeter lesions, as you know, in the cirrhotic liver, my patient has a F3, F4. It's difficult to pick up a 1 centimeter. It's a very difficult ultrasound by myself and then confirm with MRI. But the other tumor markers actually push me strongly to look for the presence of tumors, because the raised C 19.9 and CEA. So that's my comment.
Right.
Yes.
Okay. Thank you very much for your wonderful comment. I'm changing, but the situation, the liver hepatology in Japan is changing. But I've been happy enough to be around in Asia. And so Asia has a lot of young patients. This is a matter of the senior people has a chance to get any cancer at all. So if we are saying, I'm just seeing a hepatologist, I'm a hepatologist, no way. I mean, got to see everybody, everything. Otherwise, they may be dying. So that's my point. So can I proceed? Izumi-san, next, please. So I think I like Asia because there's so much situation different, economically, everything different. Patients age.
So varies. And but Japanese government are, well, not really welcoming, but they can support us to do this kind of the medical practice, our hepatology clinic. And then SVR, another question and discussion is, SVR due to DAA may be different from the interferon. And then do you believe that or not? Of course, maybe interferon has some anti-tumor effect, but does it last? I don't really think so, but we need the data. For that, I look back our own data, interferon era, 2000 published, 2002, and then 4 figures you see. Again, this time we compare the SMR, general population data, with our patients. About this 4 data, 4 figures, on the left upper side, A is untreated chronic hepatitis C. Obviously, those general population, those are dots. Dots are above the ones of our patients, survival curves. And B is all treated chronic hep C. basically there is not much a difference. I may be slightly maybe above it, but those days interferon treatment, virus eradication rate is only a matter of 5 to 10%. Why genotype 2 may be much higher? You remember that, those discussions, very hard discussion those days. And the C is the one comparable to our data. In other words, these are the group of patients, 800 some patients, SVR at that time shows chronic hepatitis, having a chronic hepatitis, and then followed over 7, 8, 9 years to see the survival curve. This is very similar to the one we saw. I just showed you our cohort treated by DA. So basically, from this simple comparison, but in years, 14 years, 2022, so 20 years, 21 years differences. Drug is different. But SVS situation brought up this very similar, comparable comparison between the two lines or two dots. And this is a non-SVR. So I think I personally don't feel that any differences. And then maybe many people agree with that. So finally, I may stop here and then may want to have an opinion about these particular cases in any aspects. I'm very welcome. All right. Anybody? Anything about these situations, SCV, or testing of 3 markers? How do you think? I cannot do my hepatology clinic without 3 markers. I said AFP, AFPL3, and DCP. Unless otherwise, it's impossible. So I don't really understand why you discuss about those. AFP alone versus ultrasound, no way. So many cases without AFP elevations. I need the AFPL3, I need a PIVCA. And Sheena knows because Sheena judges the treatment effect by declining of the optimal markers. So it's the way. And I think many people will agree there is no difference once you clear the viruses. So Nakano-san, could you go ahead? Then finally, okay, what are the causes of death of these patients? And then this is a very small cohort, but may represent others. And if you have total 32 deaths, liver-related deaths was 17 patients. Hepatocellular carcinoma is 11, and then cirrhotic and other non-malignant liver condition is 6. And the other cancer, as I mentioned, almost a similar number happened, but somehow, maybe because they come to my clinic and the early detection of the tumor of the other than liver may brought the incidence of the death is not that high. Out of 50-some patients, only 4 patients died. And the others are cardiovascular. So even though the comparing to the standard mortality rate, the patients suffering the liver disease is the most. So can we predict among those SVR, which may be related to the liver diseases? So prediction of hepatocellular carcinoma or other malignancy possible. In fact, other malignancy are not possible, in fact, because that can happen in such as I showed that cholangiocellular carcinoma or stomach colon cancer and such. But about hepatocellular carcinoma, multivariate analysis, ages, BMI, total bilirubin, albumin, AST, LT, and gamma GTP, and platelet count, and elastography, the only thing significant was history of SCC. Well, people may say that obviously, if there is a history, history of FCC or the past history of SCC and treated, maybe they may have the remnants, the high possibility, the unsuccessful or insufficient treatment may cause another tumor. But is that really true? Therefore, I wondered whether they are the really remnants of SCC by previous treatments. So I will talk about your experiences if you have any questions.
Yes, the question is when you try to predict the occurrence of the cancers, what kind of the markers or the parameters you use? Obviously, fibrosis score is high. Maybe you may expect higher incidence of cancers afterwards in SVR. But do you have the same experience that SCC history has the strongest predictor for the recurrences? May I have your opinions? Dr. Rinogani or Hasmik? Dr. Hasmik or Ashok from ILBS or Dr. Dogmeji? May I have your opinions? I mean, obviously, if you have a kind of insufficient treatment previously, they may recur, right? So the parameters is one of the strongest predictors, might be the previous history of the hepatocellular carcinoma. But the question is whether those are prone to have the cancer tend to have the same neoplasma even after virus eradicated. Do they have? That's the question. And then maybe prone to means what? Which may not be defined by the extent of fibrosis or whatever. So that's my question. It's really a remnant, or there is a certain potential parameters and parameters in background. So Abbas, how do
yes, I think this may be the fibrosis that is there, and extensive fibrosis, whatever the cause may be, whether this is hepatitis C or some other cause, and these are the patients who are prone to hepatocellular cancer. So this may not be the DA, and these patients who have previous history of hepatocellular carcinoma, even if we have totally eradicated, there might be small synchronous lesions that might have been missed, or it may be that ground which is very oncogenic in any case, and these are patients who may develop hepatocellular carcinoma in any case, whether you have eradicated virus completely or not. So I think this is degree of fibrosis and the damage, like we heard in the previous presentation about the role of MAG2 binding protein glycan, which is M2-BPGI, that is elevated in the patients who have type HCV-related hepatocellular carcinoma. So I think this is a fibrosis, degree of the fibrosis that is more important in hepatocellular carcinoma.
Yeah, that's what I saw. But in this small cohort, unfortunately, fibrosis extent does not predict the recurrence. I mean, occurrence of cancer. Well, maybe it's because a small sample size, but that's my own experience. So that's why I'm saying. All right, so Nakano-san, please, could you go?
When you have a recurrences, how do you define that's a recurrence?
Right.
The same tumor, same clones, or the different clones? How do you do that? Well, we do in this way. We establish a genomic, hopefully routinely, genomic diagnosis of the hepatocellular carcinoma or any sort of malignancy. In fact, it's studied in many countries, like foundation ones or the other oncopanels. But we created our own 72 genes by in-house at our genome analysis centers. And then the questions about whether they are the same clones or not. Well, it can be also called the intrahepatic metastasis, same drivers. And the other one is a multicentric recurrence. And so then you may say different clones. So if it's a remnant, maybe the driver might be the same, driver genes or oncogenic may be the same. Not many cases actually happened in this way, but still we are able to retrieve 4 cases, 10 tumors. and studied. And then this is a heat map analysis about this 78-year-old gentleman. And the T1 is 2017 July. And the 22, so 7 years after, he showed the recurrence, 28 millimeter to 30 millimeter. Well, first tumor shows a driver mutation TP53, but the second, it was not there, and then seems like other mutation was found. So maybe this is a different clones. The second case, a 69-year-old SCC65, 3 tumors. And then actually every 3 tumor has a different clones and then different drivers. So again, a duration between the 2009 and 2009, 10 years, it's a different clones. And the third one, there are 3 tumors, and then 2 tumors before the DAA show the same drivers, TP53. But the third one, T3, 2020, 8 years after, didn't have it. So again, this is different clones. So 3 of 3 are different. How about the last one? Interesting part is that before the DAA, it's the same clones, obviously, and then duration is 2 years and matter. But the fourth one is also a 54-year-old man, and he had 2 tumors before and after DAA. Actually, 4 different sites we took from one nodule, and then inside the nodules, basically they are same, no differences. So intratumor heterogeneity regarding the DNA concerns, there is no difference. That one not found in the T2. So it's not that simple. Maybe somehow the liver which experience the tumor may have higher potential than others. That's why analysis, multi-meta analysis left probably the previous history of the cancer premier via a kind of one careful warnings to you when you follow the patients carefully. So we suspect highly oncogenic potential in cases which was experienced CC may not be due to simple remnants and then prevalence remnants. So today I was asked to present my case. So even one single case experienced the cholangiocellular carcinoma for 85 years old, if you follow. And then maybe there is some study in that SBI patients, cholangiocellular carcinoma may increase. I do not really know, but I present my own patients and then raise several questions. I'm very happy and appreciate to have your opinion on this case. And ground rounds, I'll stop here and then thank you for your attendance. Well, I hope see you soon. Omata from Japan. All right, thank you for your attendance. 9:15 in Japan. Maybe the same in Beijing, Jidong.
Yeah,
right.
Thank you.
Thank you.
Thank you.
Yeah. Bishama, thank you. Manochi.
Yeah,
Where is the
thank you, sir.
Shimsari?
Thanks for this excellent presentation.
Shimsari
Thank
is
you very
working
much.
still? Oh, Diana, how are you? So, Tamandi, everybody, Shina sensei, how's that? I need a comment from the president.
Thank you. So I enjoyed the program very much. So maybe so we will have the next ALCAP programs quite soon.
All right, thank you.
Yeah, next month.
Yeah. All right, okay.
All right, thank you, sir. Thank you very much. Thank you, everybody.
Thank you.
Goodbye.
Thank you,
We end this
everyone.
session. Thank you.
Right. Okay.
Thank you for your
Hasmik,
excellent talk,
bye-bye.
Professor Amada.
Yeah, thank you.
Thank you.
Right. All right, see you.
See you.
Chowdhury, thank you. Yeah,
Bye-bye.
Sensei.
Hi.
Ojirao, thank you.
Thank you very much. It was excellent.
Yeah.
Okay.
All right. See you
Professor
soon.
Committee.
Right. Okay. Good. Bye bye.
Yes.
Bye
Bye bye.
Bye bye.